So basically, I welcome all on this another online session of Jaipur Surgical School. So just a brief introduction about this Jaipur Surgical School. This is an online initiative that has been started under the guidance of Professor V.K. Kapoor for general surgical trainees, basically from Middle East and low-income countries. So we are conducting this session every Friday, 3 to 4 p.m. And we are open to the suggestions so that we can improve this session. And also, maybe if the students from these countries want to change the time or any other topic they want to include, we can include that. So, in this series today, we have a very important discussion on an important topic, that is the post cholecystectomy problems. So, this is the most common surgery which is being performed by every surgeon, general surgeon or a GI surgeon, and there are many problems that encountered in a post-operative period, so which are usually not very simple to elicit. So on this topic today we have a eminent speaker, Dr. S.K. Mathur sir, with us, and to moderate this session we have Professor V.A. Saraswat. He is currently the head of hepatology in Mahatma Gandhi Hospital, Jaipur, and former professor from Sanjay Gandhi Postgraduate Institute, Medical Sciences, Lucknow. And Professor Kapoor sir will also join us shortly. Meanwhile, I request Saraswat sir to please moderate the session and start the session. Thank you, sir.
Thank you, Dr. Piyush. Good afternoon, Professor Mathur, and good afternoon to all the listeners and people online. As I think Piyush has introduced you about the Jaipur Surgical School, I would request all the participants to make the best use of this facility, because Dr. Kapoor has put together a group of very senior and experienced faculty members who can deal with the usual problems that are faced by general surgeons as well as surgical GI surgeons. So as Piyush introduced the topic, we'll be talking about evaluation and management of post-cholecystectomy problems oblique symptoms. Cholecystectomy is done as one of the commonest surgeries done. And as you all know, gallstones are silent or they may be symptomatic gallstones. Once surgery has been done, the set of symptoms that may arise or that the patient may still complain of despite having his gallbladder out has usually been referred to as post-cholecystectomy syndrome. Now, this includes a variety of topics. This could be problems of an organic nature related to underlying problems like retained CBD stones, post-cholecystectomy, bile duct injury or strictures, a sump syndrome, or even recurrent pancreatitis, which would be organic diseases related to symptoms that may arise in the post-cholecystectomy population, or more often problems that are related to the GI tract, dyspepsia, bloating, fullness, reflux symptoms, even diarrhea, post-cholecystectomy diarrhea and bile salt diarrhea have been described after cholecystectomy. This becomes a very mixed bag and difficult to analyze because these are often symptoms that may have been present but not highlighted by the patient prior to surgery, and whether these are de novo symptoms arising after surgery or they were actually present and unrelated to the presence of gallstones are the various scenarios that the clinician has to address once patient comes back to him after cholecystectomy and has some complaints or the other. You all know, would be aware that Professor S.K. Mathur is one of the most senior GI surgeons from India with an extensive experience and practice in a vast area of surgical as well gastroenterology as well as HPB surgery and liver transplantation. And there would be very few people better fitted to answer this talk from a surgeon's point of view, that the guy whose gallbladder you have taken out and who has come back to you with symptoms, how should you approach this problem? So with these few words, I'll request Professor Mathur to share his screen and we can then begin with the presentation.
Good afternoon, everybody. Thank you, Piyush, and thank you, Professor Saraswat, for that kind introduction, both to me and to the topic itself. Let me just see. Yeah. So let's define that. I know that it's meant for the PGs, both those who are going for general surgery as well as the GI surgery. So let's define what are the learning objective today. One, of course, what is this post-cholecystectomy? How do you define it? What is its incidence? What is the differential diagnosis? What is the evaluation of suspected PCS, whether it is clinical or investigative? And finally, the management and little part on the prevention also, because we should also know that if we can prevent this syndrome, it is better than treating it. So, as Professor Sasu said, that the gold standard treatment for gallstone disease is cholecystectomy, and 80 to 85% of patients will be relieved of their symptoms. However, as per the literature, 10 to 15% of the patients continue to have. Yes. So basically, should I repeat this learning objective, or we have already covered that, right?
Yeah.
Covered, sir.
So the post-cholecystectomy symptoms can persist in 10 to 15% of the patients, and these are then grouped as a post-cholecystectomy syndrome or symptoms. Now, some history, it was Mohammed and Sirer who 1947 described this post-cholecystectomy syndrome. So, and if we look at the definition, it is defined as a complex of heterogeneous symptoms consisting of upper abdominal pain and dyspepsia, which can recur and persist after the cholecystectomy. Now, if we look at from purist point of view, this term is inaccurate because it encompasses the biliary and non-biliary disorders, which are sometimes possibly unrelated to the cholecystectomy. So, the better definition is it is the term should be used to describe the persistence of biliary colic or right upper abdominal pain with a variety of gastrointestinal symptoms similar to those in patients with cholecystitis prior to cholecystectomy. So this is important. It is the recurrence of the same symptoms which were there before the cholecystectomy. And as the name suggests, the syndrome can present either a continuation of the symptoms caused by the gallbladder pathology or maybe development of the new symptoms. Now, what is the incidence? As per the US data, it's 10% of the patients who have undergone cholecystectomy have been diagnosed to have the PCS. As per the international literature, the incidence varies from 5 to 30% of the patients who have undergone the cholecystectomy. I thought it is important to refer to the Indian data as well. Though I could find one study which was published in 1995 of 171 patients, of which 18% were found to have post-cholecystectomy symptoms, of which 70% were attributed to organic cause and 30% were labeled as a essential dyspepsia. So, what is the differential diagnosis when the patient comes with the post-cholecystectomy persistent of symptoms or development of the new symptoms? That we can actually classify them into extrabiliary disorders, that is gastrointestinal causes, biliary disorders, extraintestinal disorders, and finally the psychosomatic disorders or the functional disorders. Truly speaking, this is the only condition that is psychosomatic disorder which should be labeled as a post-cholecystectomy syndrome. The rest are post-cholecystectomy symptoms. So, what are the extrabiliary disorders which can be responsible for the symptoms persistence? One is overlooked reflux esophagitis, hiatus hernia, peptic ulcer disease. Okay. There the symptoms can be confused with symptoms of the cholecystitis. Patients having attacks of pancreatitis or having pancreatic tumor, mesenteric ischemia, diverticulitis, other bowel pathology, and in our country, I think one should remember the abdominal tuberculosis as well, and finally the irritable bowel syndrome. On the other hand, if you look at the biliary disorders, now this can include the pre-existing condition which remain undiagnosed or unsuspected, or it could be so biliary disorders, when we talk about, there can be pre-existing conditions which have been missed out, or it could be iatrogenic related to the cholecystectomy. Now, if you look at the list of the iatrogenic condition, the retained calculi in the residual gallbladder remnant, I will elaborate on this subsequently. Same way, cystic duct remnant, which have a retained stone, can have a fistula, can have a granuloma development, or the neuromas, and the biliary strictures. Now, these are all iatrogenic. On the other hand, there can be pre-existing condition like missed or retained CBD calculi, a choledochal cyst which was not suspected or not diagnosed pre-surgery, biliary dyskinesia or the sphincter of Oddi dysfunction, papillary stenosis, and finally the bile salt induced diarrhea. I think and during the comments, and Dr. Saraswat can comment more on this. And the bile leak. Now, post-operative bile leak is not truly post-cholecystectomy syndrome. It's a complication, but still some people have classified into the PCS. Now, extraintestinal causes, which can be responsible for the pain, are the intercostal neuritis, wound neuroma, and the coronary artery disease. I think some of you should know that there is called condition known as cholecystocardiac link, where a patient with cholecystitis can present with the symptoms like coronary artery disease, can have even ECG changes and do the cholecystectomy, and they get relieved of their symptoms, and the ECG changes also disappear. But at the same time, the in the post-cholecystectomy scenario, if there are pain, one should look at the coronary artery if there is a particular age group of the patient. Then finally, what we call as a truly post-cholecystectomy syndrome is because of the psychosomatic or functional disorders, which can be a psychiatric or neurological disorders, or can be an unexplained pain syndrome. So what are the common symptoms with which these patients can present to you? Again, they can come with the fatty food intolerance, nausea, vomiting, flatulence, heartburn, indigestion, diarrhea, and jaundice. And most common is the intermittent episodes of abdominal pain, where it mimics like originating from the gallbladder. Now, these post-cholecystectomy symptoms can present early in the postoperative period or manifest months to years after the surgery. So there is no fixed time for presentation of these patients. As per one of the study, 28% of patients present with the mild symptoms and only 2% have a severe symptoms. This study also found that the functional disorders are responsible for PCS in 26% of the patient. Now, one study identified that the younger patients have more chance of getting the PCS, and same way, the females have a higher risk of developing the PCS. Are there any risk factors which can predict the chances of patient developing PCS? Yes, an emergency surgery where it's more likely that the subtotal cholecystectomy is being done, or chances of bile duct injuries are high. Absence of cholecystectomy. When the cholecystectomy is done in absence of cholecystectomy, chances of PCS are to the tune of 30%. Increasing duration of the preoperative symptoms again has been found to be a factor which could predict that chances of PCS are there. And lastly, if intraoperative cholecystectomy is done, that is also considered as one of the factors which can be responsible for development of the PCS. Now, how do you evaluate these patients? He's undergone the cholecystectomy and now comes with the symptom complex. So how do you evaluate? The most important thing is the history. An accurate history analysis of the present symptoms, which tells you from where these symptoms are originating. And also to look into what were the pre-cholecystectomy symptoms. so that you can compare whether these symptoms are similar to what they were there beforehand. And of course, the detailed physical examination will find any abnormality, particularly in the spine. Okay. Now, once that is done, then one should also do the detailed analysis of the what was the pre-cholecystectomy workup of this patient, what was the pre-cholecystectomy diagnosis, what were the surgical and pathological findings, and were there immediate post-operative any problems in the form of bile leak or in the form of unexplained fever or development of jaundice. And this all help to identify the specific etiology. Now, further workup depends on what clinically you suspect to be the cause for these symptoms. So, now, as far as if the patient has got a biliary disorder in the post-op period, most of the time symptoms will be either in the form of a right hypochondric colicky pain or right hypochondric pain radiating to the back, or there may be fever if there is cholangitis, or there may be jaundice, and the 35% patient may present with the diarrhea or nausea. Now, what should be the initial workup? A complete blood count to eliminate any infectious etiology. Now, liver function test is done. Remember that in a non-jaundice patient, the bilirubin, AST, ALT may be normal, but a rise in the GGT or alkaline phosphatase may point that there is a likelihood of the partial biliary obstruction or some biliary pathology. So one should carefully look for the raised GGT and alkaline phosphatase. Serum amylase lipase rise may be responsible for point towards the patient have pancreatitis. Now, sometimes when you do the first time the sets of investigation, they come normal. It is better to repeat them when the patient is symptomatic. So in between the symptoms, if you see, all the investigation may come to be normal. So it is important to repeat them when the patient is symptomatic. Now, further investigation will depend what do you suspect as the possible cause. Whether it is extrabiliary, that is gastrointestinal, whether it is biliary, whether it is extraintestinal, or whether it is a psychosomatic disorder. So, if extrabiliary gastrointestinal cause, the most common we know is the reflux esophagitis and hiatus hernia, which can be associated with the gallstones and the peptic ulcer disease. Here, the investigation choice will be upper GI endoscopy as well as esophageal manometry. While if the possibility is that the pain might be originating either from the pancreas or from the small bowel or the large bowel or from unexplained abdominal area, then one of these investigations, whether it is CT abdomen, MRI, EUS, colonoscopy, or barium study, either alone or in combination, may help in reaching to a diagnosis. On the other hand, if a biliary disorder is suspected, which we have already talked about, what are those biliary disorders? In that case, of course, the sonography abdomen and pelvis is the first investigation choice. Now, I've put that X-ray chest and abdomen. I don't think today it has got much of meaning, except if you see the calcifications, you can suspect there may be tuberculosis, or you can see the calcification in the area where the pancreas is there, you can suspect chronic pancreatitis, or you can think of the bowel obstruction if they are dilated bowel loops. Otherwise, the sonography abdomen and pelvis is the most important and quickest and inexpensive and non-invasive method to evaluate both hepatobiliary, pancreas, and surrounding areas. So the sonography can tell you if there is a large residual gallbladder with a stone, if there is a biliary tree dilatation, whether intrahepatic bile dilatation. Now, remember that post-cholecystectomy, a CBD up to 10 millimeter is considered normal. But any dilatation of CBD beyond 10 millimeter should raise the suspicion of a distal biliary obstruction, be it retained stone, be it CBD stricture, ampullary stenosis, or a missed choledochal cyst in the pre-surgery period. Now, the gold standard for evaluation of the biliary pathology in a post-PCS situation is the MRC. It can tell you whether there is any retained or residual or new stone in the CBD, if there is a large gallbladder stump with a calculi as seen here, or if there is any choledochal cyst. It also will help you in evaluating if there is a biliary stricture, the post-cholecystectomy. That means that it is an iatrogenic. Now, when will you ask for the CCT in the patient with the PCS? Basically, when you are suspecting a mass lesion, either the ultrasound is showing something, or you are suspecting in a patient with, if there is a history of weight loss or there is a history of jaundice, and you are suspecting either a cholangiocarcinoma or a carcinoma of the gallbladder and remnant gallbladder after subtotal cholecystectomy, or you are suspecting a pancreatic pathology, whether it be a tumor or be a pancreatitis or its complication or chronic pancreatitis. Now, cholecystography, or what is commonly known as the high-def scan, is indicated if there is suspicion of biliary dyskinesia, sphincter of Oddi dysfunction, papillary stenosis. That means it will be used only after you have ruled out other biliary causes with the sonography and MRI. Okay, then only the high-def scan comes into picture, because these are rare conditions and this is a diagnosis by exclusion. Okay, now remember that differentiation between stenosis and dyskinesia is not always easy. Now, those who don't know, how do you interpret these scans? It is the static images and time activity curve is used in it, which gives a semi-quantitative information. So, in case of a patient with a sphincter of Oddi dysfunction, there is increased time to hepatic peak, delayed biliary visualization, delayed clearance of the radiotracer from the dilated bile ducts, and the prolonged biliary to bowel transit. Here there is a picture, you can see this bile duct is full of tracer activity, and you don't see anything entering into the duodenum, which suggests that there is possibility of either biliary dyskinesia or the papillary stenosis. Now, what is the role of GI endoscopy? Yes, a lateral duodenoscopy can show the pathology around the ampulla or by direct visualization, and one can take the biopsy. Endoscopic ultrasound plays an important role if there is cystic duct remnant stone suspected, if there are CVD calculi, there is a small one which are missed by the MRCP, small biliary tumors, a small cholangiocarcinoma, or a pancreatic tumor, and the groove pancreatitis. If one suspects the sphincter of Oddi dysfunction, the gold standard diagnosis should be by ERCP with biliary manometry. On the other hand, if the cause suspected to be extraintestinal cause, such as intercostal neuritis, wound neuroma, then one can go for CT and MRI of the spine, soft tissues in that area. If a coronary artery disease is suspected strongly, then a 2D echo and coronary angio may be called for. But when it is a psychosomatic disorder, okay, then it is evaluation by the psychoanalyst who should be looking at these patients. Now, when we come to the treatment or management part, now it will depend on what the etiology is. So we can have pharmacotherapy, we can have endotherapy, we can have a surgical therapy, or finally the psychological therapy or the meditation. Okay. So where the pharmacotherapy is indicated, if the cause of symptom is the GERD or gastritis, then you can use the PPI or with the prokinetics. If it is irritable bowel syndrome, then bulking agents or the antispasmodics or sedatives may be beneficial. For patients with the diarrhea alone, which is thought to be because of bile salt induced diarrhea, it may be cholecystectomy. One study demonstrated that patients with dyspeptic symptoms, which correlate with the concentration of the gastric bile salts, can be benefited with the binding agent, again like a cholecystectomy. I think Professor uh, Saraswat will be able to elaborate on this much more than I can talk about. Now, as far as endotherapy is concerned, that is sphincterotomy and biliary stenting, it will be indicated when the cause for symptom is either CBD calculi, a stone in the cystic duct remnant below the level of the clip can be tackled by the endoscopist. A CBD structure like seen here can be again tackled by the repeated biliary stenting. Papillary stenosis, sphincter of Oddi dysfunction. Here, the sphincterotomy is the treatment of choice, which is done endoscopically. Now, what is the role of the surgeon in all this? So, surgical therapy is an option when there is a well-established and identifiable etiology which is known to respond to the operative intervention. Remember these words. It's well-established, identify etiology, and you know that it is going to respond to the operative intervention. Okay. So what are these? Amongst the non-biliary causes, basically pancreatic or gastrointestinal tumors. Amongst the biliary causes, if it's a remnant gallbladder with or without calculi, remnant cystic duct with or without calculi, presenting with the classical symptoms, and there no other cause is found, then the surgical revision surgery or excision of the remnant is indicated. If the Meniere's syndrome is the cause, if there is CBD stricture which doesn't respond to the endotherapy or it is not amenable to the endotherapy. And finally, a choledochal cyst which was missed out in the pre-cholecystectomy workup. Now, we all know the subtotal cholecystectomy is a bailout procedure these days used whenever there is a difficult cholecystectomy, particularly the difficulty in dissecting the callous triangle, and there are enough paper talking about that. But is it without any price? Now, we know that if the stumps are large, they can get inflamed, particularly if there are stones lying there, and the patient can present with the stump cholecystitis. The incidence has been reported to be 5% if following emergency cholecystectomy. MRCP is the investigation of choice, and treatment here is a laparoscopic or open completion cholecystectomy. Same way, the remnant cystic duct stump syndrome, or you can say that there is a stone there, lithiasis. There is one study which has reported 12 patients, 6 required surgery, and 6 were managed endoscopically for removal of the stone. As far as the extraintestinal causes, it depends what cause is there. The treatment will be according to that. Now, psychosomatic or functional disorders. People may differ with me. Again, Professor Saraswat can elaborate, or when Vinay joins, he may have something to say. I have no evidence to say what I'm saying here, except my personal experience. The reassurance to the patient is the most important thing. If there is no organic cause found, and I do believe that some sort of meditation or yoga does help these patients, and this is what I advise to my patients. I may be wrong, but my patients do feel better after all this. Okay. Now, what is the prognosis? Remember that 75% of the patients, once some intervention is done, they get the relief in their symptoms if the cause is identified. Should the patient be educated about this PCS before cholecystectomy? Yes. 10 to 15% patient who undergo cholecystectomy can develop this. Patients should receive education the possibility of developing PCS, and there should be effective communication about the possible problems. Okay. Now, as I said in the beginning, the prevention of PCS, whether the symptoms or syndrome, is the most important part. And there are 5 rules I lay down for myself and which I am sharing with you. Some of them may be controversial, and again, the moderator can comment on that. First thing is mere presence of gallbladder stones should not be an indication for doing cholecystectomy. Okay, that holds true for all asymptomatic gallstone. Not to do cholecystectomy for dubious symptoms such as dyspepsia, particularly if there are no stone disease. Do thorough clinical and investigative evaluation to rule out any associated biliary pathology before doing cholecystectomy. So a missed out choledochal cyst, missed out a CBD stone, or some other pathology should not happen, or say biliary dyskinesia. Okay. Subtotal cholecystectomy is a bailout procedure, but only when it is unavoidable. Okay. Today it has become fashion that, oh, we do the cholecystectomy. If it's difficulty, we'll do the subtotal cholecystectomy. I've shown you the pictures. I will show you one more. So do cholecystectomy. Now, instead of doing in an acute situation, cholecystectomy, you can do the cholecystostomy. If you don't have facilities for intervention radiologist, you can do yourself laparoscopically. And this can be followed by elective cholecystectomy as an alternative to avoid the problem of remnant gallbladder stump. And I'll share with you the case who had undergone cholecystectomy. The person knew that it was difficult cholecystectomy triangle, so he didn't clip left behind a part of the gallbladder and put the drain wisely, which was done. But the post-operatively, the drain persisted for 6 months. All types of endoscopic therapy has been tried. Dr. Saraswat can identify there are 4 stents have been placed there, but the biliary leak didn't stop from the cystic duct, that remnant stuff. And then finally, patient has to be taken for surgery. You can see here the drain coming into the gallbladder, which is covered by the omentum in the colon. Now, after adhesiolysis, you can see the stump of the gallbladder. And this is the, you can see the critical view of safety. You see the cystic duct, cystic artery, and the bile duct is here. ICE was used in this case. And here the safely the cystic duct has been clipped and the remaining gallbladder will be was removed. Now, this is for Dr. Saraswat and for Dr. B.K. Kapoor. This is something editorial which me along with late Dr. S.R. Nayak, we wrote about diagnostic evaluation of the PCS way back in 1987. And I was looking at this paper, and from there, what advances we have made. I think MRCP use is the most important thing today, and this subtotal cholecystectomy business. Finally, remember that the management evaluation of the PCS is a team effort. The team approach should be applied. It is the surgeon, the gastroenterologist, who should evaluate the patient, localize what is the cause, and then decide whether it requires a therapeutic endoscopic treatment, or it is required surgical intervention, or it requires only the medical treatment. And of course, sometimes we may take the help of the intervention radiologist. Thank you for your kind attention.
Thank you very much, sir, for an excellent overview and a thorough coverage of a complex topic, a topic that has been around for decades and still puzzles a lot of us. So if you could stop sharing your screen, then I think we can see the others and maybe we can have a few question answers.
Yeah.
Has Vinay joined us, or he's still preoccupied? So unless while we wait for any questions or queries from people in the audience, I'd like to begin with a slightly provocative question to you, sir.
Yeah.
And that is it time now to discard the term post-cholecystectomy syndrome? Or while in lower case, it may be appropriate to retain the term post-cholecystectomy symptoms as a broad generic coverage of any symptoms that occur after cholecystectomy. I say this because, as you have shown in your slides and very thoroughly, almost all the manifestations except the limited subset of biliary symptoms and complications are other entities which have a clear cut diagnostic and a management algorithm. And once you identified, say, reflux disease, diverticular disease, or ulcer disease, well, then why call it post cholecystectomy at all? It is that entity, and that should be managed according to the standard approach or guidelines for those conditions. And the biliary problems, which you have shown in the end and as well as in the beginning, can be fairly difficult, and they are either iatrogenic or overlooked problems that were pre-existent, can be rectified by appropriate intervention, surgical, endoscopic, or otherwise. So why exactly should we continue using this term? It was okay 40 years ago when we didn't have the investigative armamentarium to pinpoint and identify specific entities. That editorial you showed with Professor S.R. Nayak was very nostalgic. I think that was written in that era where we did not have ready access to ERCP, MRCP, ultrasound, endoscopic scintigraphy, and so on. So then it would have been justified to use this rubric. But what are your thoughts now?
So I agree with you that one, this syndrome should be reserved only for those where there is no organic cause found after thorough workup, and that is what we call as psychosomatic disorder. It can be kept only for those small group of patients, which will be a rarity, which should not be common. Number two, one should remember that, as I mentioned in the prevention, that mere presence of the gallstones and some dyspeptic symptoms,
Yes, that's a good point.
okay, doesn't mean that they are originating from the gallbladder. And patients should not be rushed into the cholecystectomy in these cases. Here,
Absolutely right. So I fully agree with you.
the patient with the, see, reflux is so common these days. Okay. And that can mimic like as if they are discomfort, because they point toward the right hypochondrium, they point toward the epigastrium. And sometimes they fail to describe their symptoms. That thorough clinical evaluation of the patients, that whether these symptoms can be because of associated condition, should be looked into. Because if it is an asymptomatic gallstone, the patient basically has got a GRD, you treat them with the PPI, it doesn't require cholecystectomy. So,
right, sir. So I think that is the major thing is that good evaluation to establish the symptomatic status of gallstones before undertaking cholecystectomy, and then a thorough evaluation post cholecystectomy for identifying GI. You've told us biliary, extrabiliary, and extra GI conditions that have been very well classified, can pinpoint the problems. And even what we call functional and psychosomatic, you send him to a good psychiatrist or a psychologist, they will give him a label of some depression or reactive psychiatric or psychologic syndrome, amenable to psychotherapy, or what you've told us, the way, yoga and meditation are now well established treatments adopted by the psychologists for these conditions. So we can, even in those subset which you're calling the syndrome now, can give them a clear-cut label of a psychiatric disorder, which will then respond hopefully to the appropriate therapy. The other question was
I've
that
got a little reservation on this, if I can interrupt you. See, I've seen the moment you say the patient has got a psychiatric problem, you know, it's a stigma to him, to the family. I think if you found that there's no organic cause, the reassurance to the patient is, see, you don't have, see, mainly why the patient is scared. He thinks that he should not have a cancer. Okay, that is the most dreaded condition. The moment you assure them that, okay, you don't have a cancer, I can give you 100% guarantee as of today. Later on, what happens, nobody can predict. That relieves their mind. Okay, and most of their symptoms slowly disappear if you tell them to get involved in your work or other activities of the hobby, keep yourself occupied, or talk to the family members and find out where the trigger. Okay, so I think as a clinician, we should not say that, oh, I am a gastroenterologist, I am a surgeon, why should I bother about the mental? No. I think we should treat the patient as a whole, not the disease just.
Yes. So you basically have become a part-time psychologist or psychiatrist for your patient because you need to help our patients.
Yes.
So are there any
May I,
symptoms that one can
may I interrupt,
attribute
sir?
to the? So, हाँ जी बताइए. Sorry,
I'm Dr. Rajendra Desai, sir,
can you?
from Hyderabad.
हाँ, Dr. Desai, we are not seeing you on the
Yeah,
video. Is your video on?
my this thing is on. My picture is on, but not my video
Ah, right. Okay,
because
Dr.
I'm at
Desai.
home at the moment. So I prefer not to
जी.
have my home on display. Yeah, sir.
Okay.
So basically, I have used TENS therapy, that is transcutaneous electrical nerve stimulation, for these wound pains. This is more common in the area of open cholecystectomy. But with laparoscopic cholecystectomy, which has been converted to open, there is an element of dissatisfaction in the patient. And these patients tend to have more pain, discomfort, and as opposed to a patient where you have de novo said, I'm going to do an open cholecystectomy on you. So I think psychologically they are bent upon having some pain, and using the physiotherapist services to give transcutaneous electrical nerve stimulation helps. Also, gabapentin,
Sure.
uh, GABA inhibitors, they are also very useful.
Gabapentin and
Yeah,
pregabalin. See, all
yeah,
these are entities for neuropathic pain. So when you're
yeah.
using them, you are in by your diagnostic intervention labeling them as neuropathic pain, which you are treating by
Precisely,
TENS or by
precisely,
other
precisely.
electrical interference therapy and
That by and large tends to
medications.
be the commonest cause in practice. It doesn't get reported much because we don't write up wound pain because we say it's expected after surgery.
Right. Right. Yeah, and we do not really have any objective tests that document that this is it. You do can't
Yes,
do a nerve conduction velocity or anything to label it. So often it is the intervention that is required. So now, if
yes,
you
sir.
so you are specifically talking of the entity of wound pain, scar pain, or scar discomfort, many of the other symptoms that Professor Mathur has referred to have nothing to do with the scar per se, but your what you have said are very valid observations for scar or wound pain. The sphincter of body dyskinesia, I just wanted to refer to briefly, was
Yeah.
something that came up with the Milwaukee group when they started doing manometry studies, along with we have indirect measurements like what you sort of call scintigraphy, as well as symptom scoring. And I think the Milwaukee classification of type 1, type 2, type 3 SOD, this was later worked out clearly in the post cholecystectomy to show that type 1 was basically papillary stenosis, an organic disease where sphincter of Oddi manometry showed high pressures on pull through, and a sphincterotomy to divide it would abolish the pain. Type 2 remains the indeterminate type, while type 3 is clearly no delayed, no emptying, no enzyme abnormalities. OTPT alphas are normal, and scintigraphy shows normal emptying. So this is part of the group that Professor Mathur is labeled as post-cholecystectomy syndrome, that is a functional disorders of the GI tract, and SOD2, where you have some delay in emptying of the biliary tree on scintigraphy, and you may have one of the three enzymes abnormal, could still qualify as a sphincter of Oddi dyskinesia. Calcium channel blockers, etc., could be used, or sphincterotomy may help in them. So this is an entity I am not very sure how well it is being worked up and diagnosed. I know very few centers who do SO-manometry these days. Most people are managing them only with either gallbladder emptying or cholecystographic emptying and symptomatic management. And reassurance, as Professor Desai has said, quite works. Once you clearly establish the absence of organic disease, is does help a lot. Right. So,
Yeah.
any other comments or things that one would like to you would like to bring up?
So I think I'm sure that because I raised that controversial issue of subtotal cholecystectomy, which is a bailed out procedure, but this is too often used these days. Okay, I feel that in a patient with the, and this happens basically in relation to the tendency to do emergency cholecystectomy for acute cholestasis. Okay, not so much in the elective situation. And
Right.
yes, you do. It is a well-established indication to go ahead with the Lapcoli in acute cholestatis. There is no issue on that. But if you find that you have to do subtotal cholecystectomy, I will prefer to do a end up with the cholecystostomy, let everything cool down. And after 6 weeks, you can do the cholecystectomy very easily. By the time inflammation has subsided, you can do the proper cholecystectomy with the cystic duct ligation without leaving much of the gallbladder. The gallbladder in the open era, we were used to leave only when there was a meningitis, either type 1 or type 2. In the type 1, because the Hartmann pouch is adherent to the bile duct, so we peel out of the bile duct, but that part which is left behind is almost like a non-functional thing. And there the cystic duct stump used to be closed from inside. Okay, that was the technique. So here either you do that, but as I showed you the picture, it's often you will find that there are now enough series which have come, which shows that there is enough stump of the gallbladder. Means you feel when it comes as a second surgeon, you have to protect the first surgeon by saying, okay, it is cystic duct stump only. We don't say that there's a big gallbladder lying there.
Okay, right. So I think, yeah, yeah, very right. And interventions in acute cholecystitis beyond the usually mandated 48 hours that we used to learn in our student days are becoming more frequent. Possibly some guidelines and the interpretation of the guidelines, like the Tokyo guidelines and all that, do talk about doing it beyond 48 hours, as I mentioned. Maybe the reason why this is happening. And also more possibly the skills. Do you think that is an issue, that playing safe, the level, that threshold at which you play safe will depend a lot on techniques or technique available also. Decision to intervene and decision to bail out, both are possibly related to experience and skill.
Yeah, it depends on that. And but what is happening that because the acute cholecystectomy is indicated, is like acute appendicitis, we used to teach treatment is appendicectomy, emergency appendicectomy. So cholecystitis, acute cholecystitis at that time used to be conservative management, not emergency cholecystectomy. Now it has become emergency cholecystectomy. But in the process, we are ending up doing the more of the subtotal cholecystectomies.
Right. Okay, I think we have finishing time. Maybe I'll just last word on bile acid diarrhea. I think bile acid diarrheas have been diagnosed and are found in, and I think there was early literature that they are common. I mean, they are usually were picked up in people after cholecystectomy. The basically bile acid pool doesn't change. The total bile acid remains the same, but the enterohepatic cycling of the bile acid becomes following cholecystectomy when there is no sequestration of bile acid pool within the gallbladder for interprandial period. So the circulating pool cycles more often, and the content, the bile acid being excreted into the GI tract through the papilla, they increase. So but what we have looked at, and I think what I've read is that this is basically, it's not a very common entity. We seldom find it and we seldom have to treat it. But often the problem lies at the level of the terminal ileum, so that the proper absorption is not happening. When there is some kind of terminal ileal disease due to either Crohn's disease or tuberculosis or all these conditions, where the maximum absorption of bile acid happens. So the bile acids are not absorbed and then they spill over into the colon, where then they produce diarrhea. So one should look for terminal ileal disease if bile acid diarrhea is seriously being thought of. That is one. And the other is that cholestyramine binding, which has been used and is very effective in binding all the bile acids, primary, secondary, and tertiary, does relieve bile acid associated diarrhea. But one has to keep in mind that one of the commonest side effects of cholestyramine is also diarrhea. So using it as a therapeutic trial, you may not become very much the wiser. And bile acid diarrhea, special tests like looking for fecal bile acid excretion is very difficult and they're not widely available. So a cautious trial cholestyramine may be considered in some cases where one strongly feels that this is the diagnosis. But all said and done, this is seldom diagnosed these days, and I don't really recall in the last several years treating anybody with this diagnosis and having a good response to cholestyramines. Most of it is what is part of textbook reading. So I think 4 o'clock it is. So Piyush, any last words before we close the session?
I think, thank you, sir. I think the important message is that doing a safe surgery is only the small part dealing with these gallstone diseases. So need to thoroughly evaluate the patient before jumping on the surgery, and when to do that. Like sir rightly pointed out that emergency cholecystectomy are being increased because of the spending indications, but we should use it judiciously. So as there are no more questions in the chat box, I just thank both Professor Sarso sir and Mathur sir for sparing their valuable time and giving their insights on this very important topic.
दो
So
मिनट बस खत्म.
and I thank on behalf of Kabusa also, and we end this session, sir.
Okay,
Thank you
thank
very
you.
much, Piyush, and thank you, Vivek. It was pleasure
It
to
was
be
a
on the
pleasure.
same platform
Long time
after a very
later
long
since we
time.
interacted, sir. Yes, sir. I enjoyed the session, sir. Thank you so much for your presentations. Thank
Thank
you.
you.
Thank you.